I'm Mrs. Wynn. The goals of this presentation are: goal number 1, review key medical terms and diagnosis. Number 2, review anatomy and physiology related to the digestive system. Goal number 3, review ICD-10-CM codes related to the digestive system. And goal number 4, review HCPCS Level 2 codes and modifiers. In this lecture, we will be discussing medical terms, diseases, and anatomy of the digestive system. So the first thing we're going to start with is digestive system terms. Gastroenterology is the study of the digestive system. And one thing that's important to mention here that is important for all the lectures that you're going to be watching is to really know your medical terms. So when you look at gastroenterology, we break it down into its components. Gastro means stomach. Enter is the small intestine. Ology is the study of. So if you look at this and work backwards, ology, the study of, enter, the small intestine, gastro, the stomach, which comprise, the main areas of the digestive system. Gastroenterology is the study of the digestive system. So that's just a helpful thing, but it's important to really get those medical terms down. It'll help you, especially when you're trying to decipher some of the procedures and some of the diagnosis. Digestion is the process by which ingested food is broken down into smaller particles. So we take in food, we have to digest it. We cannot just take in food and use it. We have to break it down and we have to kind of transform it. And we do that through a couple of processes. In digestion, there is mechanical digestion, where we take our food and we chew it up and we grind it up and we break it down from the big pieces into smaller pieces. We also have chemical digestion. That's where we add our digestive enzymes and things like that to further break things down so that into something that is usable for absorption in our body. Absorption is the process where nutrients are transported across the walls of the digestive tract into the blood. And one area that this happens is the small intestine, specifically the duodenum. Absorption happens at various places, but the main ones are the stomach and the small intestine. And this is where the nutrients are extracted from your chewed up and manipulated food that's now called chyme, and it pulls those nutrients out to be used for the body to nourish the body. The last term, mastication, is chewing, and this is the process of breaking our food down into smaller pieces, which can then be chemically altered for absorption. Okay, so let's talk about the digestive system. First, I want to draw your attention to the top right, where we see the teeth, mouth, tongue, and esophagus. Digestion begins in the mouth. So first you chew, then you swallow, and that kind of starts the process. The actual GI system, or gastrointestinal tract, is a long hollow tube that goes from your lips to your anus. So think about, as we go through all these organs and different things, it all processing through a long tube from start to finish with all different processes through it so that we can absorb the nutrients from our food. So you have your teeth, mouth, and tongue. Then you have the esophagus, which is a long tube that goes from your mouth down into your stomach. On the left there, you'll see you have salivary glands, and they're made up of the parotid glands. Those are your largest. Those are, you have one set of each, and the parotid glands are on each side, kind of in front of your ears at the top of your jaw there. You also have sublingual gland, which is under your tongue. So you'll talk about, sometimes people have B12 that they might take sublingually, and they'll take drops under their tongue. And they say it's a sublingual supplement because That's where the gland is. You're going sublingual, under your tongue. So think of that. Submandibular gland, that occurs on each side of your jaw below the jawbone. So they're right there, kind of along the jawline. So you have these salivary glands which help in breaking down the food and the chemical digestion stuff they add. So now we go down the esophagus and we get to the stomach, which you see there on the right. There's also on the left the liver and the gallbladder. The liver does a lot of things, but one of the things it does is it creates bile. Extra bile is stored in the gallbladder. So you can live without a gallbladder. I don't have mine. I had it removed a while ago, and that's okay. But it's more efficient to have that gallbladder because it stores that extra bile in the event that you need it for digestion. So if you have a real fatty meal, you might need that extra bile in order to break down that stuff. So your liver and your gallbladder are right there. The gallbladder is that little green thing right below the liver. Then from your stomach, okay, so you've gone from your esophagus down into your stomach, and your stomach is where you actually churn the food and add acid to it and stuff. And then you move in to the small intestine. The small intestine is very long and it's made up of 3 parts. The first part is a duodenum. The second part is a jejunum. And the third part is the ileum. So when you look at all those little squiggly things that look like almost like the brain in a way, that middle part, that is your small intestine, and it's very long. That is where most of the absorption takes place. From there, you move into the large intestine. And they're listed there on the right, the parts of the large intestine. But I want to start with the cecum. So the cecum there is on your right. So if you're looking at this person, it's on your left, but it's actually on the right side of your body, and it has the appendix attached. So if you think about your cecum, think of it attached to the appendix. Most people know the appendix is down on your lower right quadrant. And the cecum is the transition from the small intestine to the large intestine. From there, we go up the right side of the body in the ascending colon, and that's another part of your large intestine. Then we go across your body in transverse colon. So we go across transverse. Then we go down. We go to the descending colon, which is on the left side of your body. And from there, we feed into the sigmoid colon, which then goes to the rectum and anus to remove the feces. So that is the whole kind of path of the digestive system. I've listed here the order. So first, number 1, we start with the oral cavity. We then go to the esophagus after we swallow, and the stuff moves down into the stomach, number 3, which we know is gastro. That's the medical term for it. We move into the small intestine, which is 4, 5, and 6, duodenum, the jejunum, and the ileum. We then move into the large intestine, which is 7 through 11, the cecum. Then we go up the ascending colon on the right side of the body, across the transverse colon, then down the left side to the descending colon, to the sigmoid colon. Then we go to the rectum and the anus, and that completes the digestive system. One thing that's important to know is that we also have what's called accessory structures. So they're not a direct part of the digestive system, but they're accessory. And those include your salivary glands, your teeth, your tongue, your liver, your gallbladder, and your pancreas, which is not shown here, but it's an accessory thing that is helped used. That's how people know it for insulin and stuff. But you have accessory organs, and then you have your main organs in the digestive system. Okay, let's talk about some of these terms in a little more detail. Your lips. As I said, digestion begins in the mouth, and your lips are the entrance to the oral cavity. Once you take in food, your teeth begin the mechanical digestion, which is chewing, and salivary glands secrete saliva and enzymes to moisturize our food for swallowing. You have 20 baby teeth, which are then pushed out and by your permanent teeth, and you end up with 32 permanent teeth. Your teeth are surrounded, the neck of them are surrounded by gums. And gums, which is called gingiva, are fibrous structures that are composed of fairly dense connective tissue. If you think of gingivitis, people have gingivitis in their mouth, the dentist will often tell them, think of the medical term for that. Gingiva is gums, itis, inflammation. So gingivitis is the inflammation of the gums. Stomatitis is inflammation or ulcers of the mouth, including the mucous membranes, lips, and tongue. So everybody knows what our tongue is. It's a muscular organ. And if you think about it, it really helps because it moves all the food around and really helps us in the mastication or our chewing to get that stuff around so that we can chew it up. It also has all the taste buds. And if you lift your tongue, you'll see that you have that thing that kind of holds it. That's called a frenulum or a lingual frenulum. So if you think of lingual, we talked about how you had those sublingual glands there under the tongue. That lingual frenulum anchors the tongue to the floor of the mouth and literally keeps us from swallowing it. So the pharynx is the throat, and it lies between the mouth, the nasal cavities above, and the esophagus below. So it's your throat area, and it's the conduit for respiration and digestion. And it's composed of the nasopharynx, the oropharynx, and the laryngopharynx. And when you swallow something and it goes down the wrong pipe, that's your pharyngeal reflex that is trying to help you prevent things from, food from getting into your lungs, that type of thing. So that's what the pharynx is. And then there's the esophagus, which is a muscular tube about 10 inches long, and it takes the food from the pharynx to the stomach after it's been chewed, mixed with saliva, and you swallow it. And it does this through peristalsis. So that is like a muscular contraction and relaxation that slowly moves the food down into your stomach. You would think that you wouldn't need that because you're going from top to bottom, from your mouth down to your stomach, but you actually do. And your digestive system does a lot of peristalsis where it can slowly move food through your digestive system very methodically and efficiently. The stomach is a large reservoir where food just churns and churns and becomes something called chyme, where hydrochloric acid gets added, and it just goes round and round until it's ready to enter into the small intestine. So the parts of the stomach are the cardia, which is up top. That's the entrance to the stomach. The fundus is the upper portion of the stomach. You have the pylorus, also called the antrum, which is down towards the bottom, and that controls the release of food from the stomach in the duodenum via the pyloric sphincter. And then you have the main body, which is the remainder of the organ. So coming into the stomach, you have an esophageal sphincter that takes the food from the esophagus and lets it into the stomach methodically. Then you have a pyloric sphincter, which takes food from the stomach into the small intestine. So if you think of the pylorus, it's down at the bottom with the pyloric sphincter. Cardia is at the top, the body is the main part, and the fundus is that top portion of the stomach. So at this point, we are heavily into digestion. The small intestine, also called the small bowel, is comprised of the duodenum, the jejunum, and the ileum. The duodenum is small. It's about 12 inches long, and it handles the majority of the absorption. It's the first part of the small intestine that gets fed from the stomach. And it contains villi, and that is necessary to draw out those nutrients and pull it into the bloodstream. So you've heard some people that have celiac disease, which is an autoimmune disorder where their villi becomes damaged and doesn't work properly. And people can become very malnourished that way because their body is unable to or inefficiently able to draw out those nutrients into the body. Next, we go to the jejunum, And the jejunum is about 8 feet long, so it's very long. Next, we go to the ileum, which is 12 feet in length. And that contains, so that's the longest of the small intestine. And it contains something called the Peyer's patch. And that decreases the bacteria content in the digestive system. So the ileum ends in the ileocecal valve. If you remember me saying the large intestine begins with the cecum, so if you think about, we end the small intestine with the ileum and we start the large intestine with the cecum, that ileocecal valve kind of blends those two terms together. And that is what connects your small intestine to your large intestine. So the large intestine is less than the small intestine. The small intestine is about 20 feet long in total, which is pretty incredible to be there in your belly. But the large intestine is only about 5 feet in length, but the diameter is bigger, which is why it's called the large intestine. Its diameter is about 2.5 to 3 inches, and it's comprised of the cecum, which I told you before had the appendix attached. So remember, that's on your lower right quadrant. Then we go into the colon, starting with the ascending colon, where food moves up across the body from the transverse colon, down the body to the descending colon, to the sigmoid colon, to the rectum, and the anus, where fecal matter is expelled. This happens through peristalsis, and it happens very methodically, very efficiently, and it's slow because we reabsorb things in the large intestine that we can reuse. The body is very good about recapturing some of the stuff it can use, for example, water. So if you don't absorb water quickly and things move through too quickly, you might end up with diarrhea, or you might end up with constipation, because things need to work in a process. And when they don't, our body experiences symptoms. Two other organs worth mentioning are the spleen and the pancreas. So the spleen is an organ that's about the size of your clenched fist. It's a purplish wrinkled organ, and it's found in the left upper quadrant of your abdomen between your stomach and your diaphragm. So this mobile lymphatic organ does two things. It's cool. In the beginning of life, it's blood forming. And later in life, it acts as a storage organ and filters blood. So it breaks down the erythrocytes, which is your red blood cells. And the most common reason, if you have to have your spleen removed, you can live without a spleen, is trauma, some sort of trauma, car accident, some people get hit in the stomach, whatever, that causes that organ to fail or not work properly, and they need to remove it. And that removal of the spleen, if you think of your medical terms, would be a splenectomy. The pancreas, the cool thing about the pancreas is that it's both an endocrine and an exocrine organ. So what does that mean? It means it's endocrine because it's hormone secreting. And what does it secrete? It secretes insulin. Exocrine because it secretes digestive enzymes, pancreatic enzymes, which feed into the duodenum. The organ is located just below the stomach, and it's a flat organ about 6 inches long, about an inch thick, and it secretes insulin into the bloodstream to help regulate blood sugar, and it exerts a significant influence on carbohydrate and fat metabolism. The pancreas, you can have an inflamed pancreas, like inflammatory disease, which would be called pancreatitis. And you can have endocrine disorders such as diabetes mellitus, and you can also have cancer of the pancreas, which is quite severe. It's divided into a head, a body, and a tail. Okay, so let's talk about the liver. The liver, the medical term is hepatic. So when you think of hepatic, think of liver. The liver is the largest organ and the largest gland in the body. So it's an organ and a gland. It's in the right upper quadrant of your abdominal cavity, and it's protected by your ribs. Hepatic means liver, and it's about 4 pounds and has four lobes, right and left lobes, but there's four lobes. It's essential for life. Unlike your gallbladder, you can live without a gallbladder, you can live without you cannot live without a liver. So you have to have that. It's vital for life. And some of the functions include storage of glucose as glycogen. So that is when we take in the glucose, we store it. The storage form of glucose is glycogen. It also stores fat soluble vitamins, which I call ADIK, A, D, E, and K, those four fat soluble vitamins, as well as vitamin B12. It's aided in the making of plasma proteins that play a vital role in the amount of blood that you have, as well as the coagulation of your blood. It deals with bilirubin, cholesterol, and drugs, the excretion of bilirubin, cholesterol, and drugs. So it's a great filter for your body for toxins that you have, and to get rid of all that unwanted stuff so that it kind of purifies things in its own way. It also makes bile salts, which are important in fat digestion and the absorption of fat soluble vitamins. So you need fat to get those fat soluble vitamins into the body. And one unique quality is that the liver has the capability to regenerate itself. So if you take a portion of the liver out, it will grow back, which is really awesome. The gallbladder is a pear-shaped organ, and it's attached to your liver, and it's the storage area. It's the reservoir for bile. So you can live without a gallbladder. It feeds that extra bile into the duodenum through the cystic ducts. As I told you, things feed into that through ducts. And if you have, say, a fatty meal and your body knows enough to say, I'm going to need a little extra bile, your gallbladder will kind of squeeze it out and feed more in. So if you don't have a gallbladder, which is called a cholecystectomy, so cholecyst is gallbladder, ectomy is surgical removal. Sometimes for me it was gallstones, a lot of people it's gallstones, or you might have cholecystitis, which is inflammation of the gallbladder. You may have to have it out for that. Sometimes people have attacks and stuff. The bile then goes directly from your liver to the duodenum. Otherwise, it will be, take what it needs and the rest is stored in the gallbladder. So if you don't have the gallbladder, your body still works. It just feeds that bile right into your duodenum. Some people cannot, they might not be able to take fatty meals because their body doesn't have that reserve for it. But that is, pretty much what a gallbladder does.
In digestion, food is changed by the organs into a soluble form to be absorbed by the body. Food in the mouth is mixed with saliva. Saliva begins to dissolve the food as the teeth grind and cut it. Food is forced back into the throat, pharynx, by the tongue. Food in the pharynx stimulates the swallowing reflex. The larynx is pulled upward to meet the epiglottis and seal off the trachea. Food goes from the pharynx to the esophagus. Food moves down the esophagus by peristalsis. The peristaltic wave reaches the esophageal sphincter and food enters the stomach. The unique muscular structure of the stomach breaks up the food into small pieces called chyme. Chyme exits through the pyloric sphincter into the duodenum of the small intestine. The major portion of absorption and digestion occurs in the small intestine. The mucosa secrete enzymes that supplement the digestive enzymes of the pancreas and liver. This completes the chemical process of digestion. The walls are covered with villi where nutrient absorption takes place. The structure of each villus contains a capillary and lacteal to pick up the digested nutrients. The nutrients are now transported by the blood to all the cells of the body. The undigested food reaches the ileocecal valve and enters the large intestine or colon. The colon absorbs water, manufactures vitamins, produces mucus, and forms and expels feces. Mass peristalsis pushes the feces into the rectum, which stimulates the defecation reflex.
ICD-10. Most of the diagnosis that you're going to need will be found in Chapter 11, Diseases of the Digestive System, but there's a few other chapters that I'd like to mention. Chapter 1, Infectious and Parasitic Diseases, could be used if you have a parasite or different things that deal with your digestion. Also, Chapter 2, Neoplasms, these are your cancers. Chapter 17, Congenital Anomalies, so things that you're born with, defects and things like that, hereditary things. And Chapter 18, Signs, Symptoms, and Ill-Defined Conditions. When we talk about things of the digestive system, dental specialists come into play here. If you've ever had a toothache, you understand the importance of these codes, so they're valid. So we need to speak the dental language to just understand the different types of specialists that there are. So the first one is your general dentist. And this is, the person you go to that cleans your teeth. They might do your fillings, your first point of contact usually for your just overall dental health. You then have periodontists, which care for normal tissue, gums, and supporting tissue around the teeth. So that, those gums surround the neck of the tooth. So those types of things. It's almost like it's expanded area. The endodontist does your care of diseases and injury of the dental pulp and the periapical tissues. They'll do root canals, not the general dentist don't, but they, everything you're getting a little more severe here. Orthodontists deal with the correction and straightening of your teeth. So we all, most of us have had braces, but we all, I think, know what orthodontist is. And an oral surgeon, they diagnose and treatment of diseases of the mouth and stuff, injuries and deformities of not only the oral cavity, but also the maxillofacial region. So they, could do TMJ stuff, and it's a little more comprehensive, but they would also do implants. Sometimes you'll go there if you need cadaver bone put into your jaw to strengthen up your jaw, some of those more significant types of things. The next thing I want to talk about is GERD, gastroesophageal reflux disease. That's what GERD stands for. And it's the reflux or backwards flow of stomach contents back up into the esophagus. And if you remember, stomach acids get added to churn the food and really break it down so it turns into chyme. And there is a sphincter there so to prevent the backflow, but every once in a while, people will get that backflow up into their esophagus, and it will cause like a burning, and it can also cause damage. So what the sensation is heartburn or pyrosis, and the two codes K21 and K29 can be confusing. So the difference worth noting is that if esophagitis is present, use K21, GERD with esophagitis. Or K21.9, GERD without esophagitis. So let's think of your medical terms. What is esophagitis? Esophago is your esophagus. Itis is inflammation. And that's not something you're going to come up with or decide. That's something that you will read in your scenario, in your medical notes and stuff. So make sure that you pay attention to that. The last thing here is your appendix. Your appendix is there all in your lower right quadrant there. It's a long little worm-like structure. Its codes K35.38 is appendicitis, which is inflammation of the appendix. And the function of the appendix has been debated for years. I think now they're kind of saying that it helps with immunity, but I don't know if that's been proven. Those are just the things that I've heard. But remember that this small structure is attached to your cecum. So the portion of the large bowel contains serious potential contaminants and bacteria, and the bowels are safe inside the intestines, and the bacteria are part of your normal function, your normal flora. If it spills into the abdominal cavity or peritoneal cavity, things can change, and you can have a ruptured appendix, Peritonitis, K35.2, K35.3. Think of your terms: inflammation itis of the peritoneum. That's your thing, which is the layer that coats the internal organs like the bowel and the bladder and the female reproductive organs. And we don't want all that bacteria and the bad stuff to come out into our cavities and stuff. So when that happens, we can have a problem. And with appendicitis, it can get kind of serious. If it bursts or whatever, your body can become kind of toxic in there. So be aware that this is something that's not super uncommon. I mean, it does happen to people, but it can manifest into peritonitis, which is the K35.2, in which case the peritoneum gets all inflamed. Or it can be an abscess, which means you have some sort of infection. It could be filled with pus, K35.3. A lot of times it can cause an ER visit. You might have to have laparoscopic surgery where they can remove your appendix, or that would be called an appendectomy. Or maybe you have a surgical, an open procedure where they remove your appendix. So it's a painful thing. It usually drives people to the doctor pretty quickly, and just know the difference between these and just be careful to know what you're coding. Hernias. So a hernia is a protrusion of part of a structure that comes through the tissue that normally contains it. So if we think about the abdominal wall, let's say you have an abdominal hernia, you can have part of your small intestine, for example, that protrudes through the abdominal wall, and that can cause a problem. It can cause a blockage. It can cause a problem with blood supply. It can actually cause gangrene because it's strangulated. So they can get pretty serious. Sometimes hernias are reducible, meaning that the doctor can push it back in, kind of push it back where it belongs. Sometimes it requires surgery, and sometimes that surgery requires the addition of mesh material to strengthen the cavity wall where it tore and the hernia, the organ pushed through. So there's different types of hernias. There's inguinal, femoral, umbilical, abdominal, and diaphragmatic. And by the anatomy, men more likely have inguinal hernias and women have femoral hernias. So those codes are K40 to K46. Diverticula of the intestine. This is when you have a pouch or sac opening from the bowel. So diverticulosis, if we think of our medical terms, osis means abnormal condition or disease. Diverticula is the diverticulum. So diverticulosis is the presence of a number of diverticula, so more than one diverticula, pouch or sac of the intestine. Diverticulitis, if itis is inflammation of the diverticulum, and that can become inflamed. It can cause obstructions, bleeding, perforations. This happens more with middle-aged and elderly people, but the code is based on the site of the condition. You have to look at whether or not there was perforation, whether or not there was an infection or an abscess, and whether or not there was bleeding. So look closely at your codes and just make sure you're coding, to the level of detail that is written in the medical report. There's also fissures and fistulas, and those of the bowels, they can be difficult. A fissure is like a tear, and a fistula is an abnormal passageway. So when we talk about the anus, these create problems because feces pass through, and when you have these fissures and fistulas, they become contaminated with this fecal matter, which can cause all kinds of bacteria, and stuff. We just don't want that in there. It can get in your bloodstream and stuff. So if you have problems healing, sometimes there's recurrent fissures and fistulas. You can have abscesses. Sometimes they need surgery. So just be aware. That's code K60. You can look in your book of the difference between fissures and fistulas so that you code them properly. Hepatitis. When I think of that, I think of the root word hepatic, meaning liver, itis, meaning inflammation. So if we work backwards, hepatitis is inflammation of the liver. And this is usually caused by a viral infection. It can be acute or chronic. Chronic is a concern because it can develop into cirrhosis of the liver, or it can develop into cancer of the liver. There's different classifications. There's hepatitis A, hepatitis B, hepatitis C. Those are the most common. Sometimes passed by sexual contact, sometimes spread by oral fecal route, body fluids, by blood. It's a concern for healthcare professionals. If you get a needle stick, you could be at risk if the patient has hepatitis. Cirrhosis of the liver is when you have chronic alcoholism or chronic hepatitis. This is end stage liver disease. And what happens is the liver gets, it loses its flexibility. It becomes tight and stiff, and it loses its function. It becomes very fibrous. And that can develop into jaundice, and it just doesn't work properly. And as we talked about before, your liver is a great filter. It goes through and kind of gets rid of all the stuff that you don't need, to kind of help do that. So when that isn't working properly, that is a concern for your body. Often you'll hear that chronic alcoholism can cause cirrhosis of the liver. So it's just something to be aware of. Cholelithiasis is another way of saying stones, like gallstones, gallbladder stones, also called calculi. It can be in the gallbladder. These stones can be in the gallbladder or in the bile ducts. People can develop small stones, cholelithiasis, and they can pass through and they don't cause a problem. When they get bigger, they can cause pain, or they can actually block the duct, and that can become a problem. Cholecystitis is inflammation of the gallbladder. So if you think about your medical terms, inflammation of the gallbladder, and you can have stones with or without cholecystitis. So you don't have to have the inflammation to have stones. So be aware when you're coding that there are codes for cholelithiasis with cholecystitis, with inflammation and without. So keep that in mind. Neoplasms are your cancers. So cancer, you can have benign neoplasms, you can have malignant neoplasms. You'll see in your ICD-10 book that you actually have a neoplasm table. And as far as the digestive tract, I'd say the most common cancers that I'm aware of are stomach cancer, pancreatic cancer, and liver cancer. And pancreatic cancer is kind of a silent cancer, and it's pretty significant. Usually when they find it, it's pretty advanced, and it can become, the survival rate isn't too good with that. Some people have had stomach cancers, and then you can also have a liver cancer as well. So you maybe find yourself coding with neoplasms of some of the digestive organs. Okay, coders, time for a little practice. Sue has a family history of colon cancer. She is scheduled for a screening colonoscopy. 4 benign polyps were found and removed using a hot biopsy forceps technique. What ICD-10 code should be assigned? Pause the presentation to solve. If you answered C, K63.5 polyp of colon and Z83.71 family history of colonic polyps, you would be correct. Note that you would not use personal history of colonic polyps because the coding scenario does not talk about Sue having a personal history, just a family history. Okay, let's try another coding exercise. Mr. Smith has been experiencing discomfort in his upper abdomen. The doctor runs some tests and determined that Mr. Smith has gallstones. He is diagnosed with acute cholecystitis due to calculus of gallbladder. No obstruction is found. What ICD-10 code should be assigned? Pause the presentation to solve. If you answered D, K80.00, you would be correct. If you look, I gave you all the ICD-10 codes below, and you can see the slight differences. They talk about with cholecystitis, without cholecystitis, with obstruction, without obstruction. So it's important to look at the detail and read those codes very specifically so that you code things properly. So let's talk about scopes. There are several scopes to view the digestive system, and the scopes have a viewing limit. This means they can only see so far. So certain scopes will go further down or up the digestive system than other ones, and it's important to know the difference. This is where knowing the anatomy of the digestive system will help you, because in order to distinguish the type of scope that's appropriate for what you're coding, you need to know how the digestive system works and the order of things so that you know when the scope is traveling a certain path, how far that goes will matter on your anatomy. So you have to know what type of scope you're coding for. One, am I coding for a rooter? Scopes that are inserted through the nose or the mouth are rooters. Or am I coding for a tutor? Am I scoping starting on the behind and through the rectum and working my way up, maybe through the large intestine? A colonoscopy is an example of a tutor, and an endoscopy is an example of a rooter. Pay attention to where or how the scopes enter the body. And remember that some scopes are designed for specific types of viewing. Another thing about scopes that are important are that you can have diagnostic scopes, which are screening for potential problems. The doctor is only looking or viewing the problem, whereas a surgical scope, they know there's a problem and they're using the scope as a way to view to correct a problem. So let's say, for example, you're going for a colonoscopy and they're just looking around and they don't find anything. That is an example of a diagnostic scope. Let's say, for example, you have some polyps that they find in your stomach. They might take a surgical scope and go through and use that scope to go through and actually take care of those polyps, in which case it's a surgical procedure. The moment the doctor does anything to correct a problem, it becomes surgery. So, for example, you have a colonoscopy, and as they're doing the colonoscopy, they find that there's a problem, and they don't take the scope out, but they switch gears and say, okay, we're here, let's correct the problem. That diagnostic scope has turned into a surgical scope. This is very important because diagnostic scopes are bundled into surgical scopes. Once a diagnostic scope turns into a surgical scope, don't code the diagnostic scope. Diagnostic scopes are always bundled into surgical scopes, assuming that the scope does not come out of the body. The moment the doctor does anything, you switch to surgical, the diagnostic is bundled. That's very important to remember. So put it in your brain. So as I mentioned, a hernia is when an organ pushes through the wall that should have contained it. So the example I used was your intestines coming through the abdominal wall. And hernias come in different types. I didn't mention hiatal before, but I did mention various types of hernias. And my point of the slide is to your facts to remember. One, what type of hernia are you coding for? That's important because your codes will vary by that. What is the age of the patient? Is the hernia reducible, meaning can the doctor kind of push it back in, or does it require surgery? And is a mesh material implanted to support the surgical site? If the abdominal wall or the supporting structure is not strong, they'll use a mesh material to strengthen it up. Most of the time, mesh material is bundled in the hernia repair. So keep that in mind. Transplants. That is the process of surgically removing an organ from a donor, which could be living or deceased, and placing it in another person called the recipient. Transplants usually happen because the organ has failed or it becomes damaged and it just isn't functioning well from illness or from disease. The facts to remember: is the donor living or deceased? Deceased meaning a cadaver, because you'll code it differently. And the four possible procedures for required for a transplant. 1 and 2 kind of are an either or. Are you removing this organ from a cadaver, from a deceased person, or are you removing this from a living donor? Then you have your backbench work, which is your harvesting of the organ and getting it ready so for the recipient to receive it. And then you have the actual transplant, which is actually taking that and putting it into the new body. So for example, if you donated a kidney, there would be backbench work to take that kidney and prepare it so that that new recipient of the kidney can receive it. And there's just work that needs to be done there. So there's 4 possible procedures, depending on whether the donor is living or deceased. Both of them will have backbench work and the actual transplant. Okay, your HCPCS Level 2 codes. There's a couple here for colorectal cancer screening, and this is used when a Medicare patient is screened for a malignant neoplasm of the GI tract. Usually we're performing a sigmoidoscopy, colonoscopy, and we'll go into those different types of scopies more when we talk about CPTs. But just know that these are your HCPCS code for colorectal cancer screening for the digestive tract. Modifiers. Modifiers are a component of CPT, and they're a 2-digit extension that help further define the procedure. The modifiers that are relevant to the digestive section are 50, which is a bilateral procedure. So let's say, for example, they're doing a repair of a cleft lip. If the code doesn't indicate bilateral, you would append the 50 modifier to that code to indicate that it was a bilateral procedure. It was done on both lips. 52, reduced services. This is done when a portion of the procedure was not performed, so not the whole thing, or let's say maybe a part of the procedure was done by another physician and the procedure itself was reduced. You didn't do the full thing. So you would use that 52 to indicate that. 53 is a discontinued procedure. So that would be when, say they had to discontinue it, say the person's heart rate was crazy and they just couldn't continue with the procedure. Or they had a colonoscope and it couldn't advance beyond something due to unforeseen circumstances. It couldn't go past the splenic flexure. So it's important to list those because and we'll talk about this more when we get into CPT, but you want to really identify what the procedure is and if there were extenuating circumstances that should be accounted for. So just a quick review. Digestive systems facts to remember. Digestion begins in the mouth. There are 3 accessory organs: liver, gallbladder, and pancreas. There are 3 small intestines. The duodenum is the first part, jejunum, and ileum. There are 5 large intestines: the cecum, the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. And the digestive process ends through the rectum and the anus, respectively. Thank you for watching. I'm Mrs. Wynn, and this video was brought to you by Absolute Medical Coding Institute. Please continue on if you'd like to do the AMCI Coding Challenge. You will be given 10 scenarios. You will be asked to provide the main term as well as the correct ICD-10 code. The answer will appear after 10 seconds. Pause the presentation as needed. Good luck. So how'd you do? If you got them correct, outstanding. And if you didn't, go ahead and review and take it again. Rewatch the lecture. This is all about learning and building your skills and your knowledge. I'm Mrs. Wynn. Thank you so much for watching this video. You're now ready for Digestive System Part 2.
Thank you for watching an AMCI exclusive presentation in partnership with AAPC. Until next time.